Thanks everyone for joining us this evening. I know that this is prime vacation time for most of the country, but again, thanks for coming out and listening to us and having an interest in the DYNABUNION system and our thoughts on how to make this a consistent and easier procedure for you. Joseph, I think we can go to the next slide. So just one of the announcements that we have is that we have a new shorter plate option for those of you that have done the DYNABUNION in the past. With the traditional plate, the shorter plate option allows you to not have to make quite as long of an incision, and also has a better contour for the medial aspect and helps the plate so it's not quite so much underneath the tibialis anterior on the medial cuneiform area. You can go to the next slide. I'm going to hand off the slides at this time to Dr. Steck, and he is going to do some introductions into Lapidus and its traditional challenges.
Hello, everybody. Thanks, Scott. And thank you to Pew for having me on this exciting topic. A little bit about the history of the Lapidus. It was started by Lapidus, first published in 1934, certainly grown in popularity in recent years. I imagine all of us have had people come in asking specifically for a Lapidus procedure due to the market pressure and popularity and patient specific marketing as well. It was interesting the first time that happened to me. I was taken a little bit off guard, but certainly popular, and patients come in asking for it by name. Overall, this is an excellent procedure for severe deformity, large IM angle, arthritis at the first TMT joint, metatarsus primus varus, hypermobile first ray classically, and a concomitant pes planus. In the past, there's been significant non-union rate as a complication, as well as dorsiflexion with first metatarsal. And in addition to the history I gave, in this next slide, I was going to give a little bit about my history with the Lapidus over the last few years as well. But the uninstrumented Lapidus, which I started doing more years than I care to admit ago, but about 20, we were pretty good at restoring the IM angle, but the other things we weren't as good at doing. Rotation of the first metatarsal to restore sesamoid position, plantar flexing the first metatarsal, and maintaining the joint apposition and compression are all things that have come a long way in the last 20 years. Applying the fixation without disrupting alignment, that was a pet peeve of mine. I'd get it right where I wanted it, and then I would get the compression and the fixation where I wanted it, and I'd lose some reduction. So I think that a lot of these things have been addressed with the DYNABUNION. We certainly want to correct the transverse IM angle, frontal position with the sesamoids and derotation, and the sagittal plane with alignment, and certainly not dorsiflexing. In addition, as I mentioned before, compression and healing, we want to be able to maintain all of that alignment by obtaining compression and holding the alignment that we've taken such care to obtain. There's some reproducible systems, the other 3D systems that can provide complexity. The others that I've tried are are significantly time consuming. I believe my experience with the DYNABUNION, it's been dramatically different than that. And I've had very good results and very good surgical experience with the DYNABUNION as well. The instrument systems, as I mentioned, directed to patient marketing by industry and practices has led to market pressures. And new instruments filled an unmet need. Before these, we'd do this all by hand and maybe use a pin to hold position. And it was unfortunately not very reproducible, at least for me. The new instruments are very regimented and time-consuming techniques that are available on the market as well. The triplanar, as a buzzword for the Lapidus system, would certainly want triplane correction. As I mentioned, the IM angle is definitely something that was the most obvious, and at least in my early practice was something I was good at doing. But the rotation and the was more difficult, and it was more difficult even if you were able to get reduction to keep reduction. As you'll see in the future presentations, many anatomies require fine-tuning of this procedure, and these triplane motions in order to obtain and keep that rotation. The DYNABUNION actually separates the IM correction from rotational correction, which is extremely advantageous. Certainly, I think the Lapidus was here to stay before the DYNABUNION, but I think this has certainly propelled this into a more user-friendly version, capable of more powerful corrections in distal bunions, can address midfoot instability, triplane correction of the first ray, and perhaps a lower recurrence rate. So in summary, we're looking for something that is reproducible. In addition, we want to decrease recurrence. We want to have low malunion rate, low complication rate. We want to be efficient in the operating room. We want to have a low learning curve. I've found that learning curve is a fancy way of saying we're hurting people. So if you do not, if you have a low learning curve, you're certainly doing a favor to the patients. And early rehab, early weight bearing, and rehab is certainly advantageous to the patients that we have. Thank you very much.
All right, so I will echo Dr. Steck in that when I first started doing Lapidus, I wasn't performing three-dimensional correction. I wasn't quite getting my sesamoid position the way that I wanted, but I was reticent to switch over because I really liked the construct that I was using for the Lapidus. So in residency, I was initially trained to do a planar to dorsal interfragmentary screw and then apply a medial plate. And I was happy because I thought it was taking care of that planar gapping and would really diminish those results of non-union. I wasn't getting a ton of non-union, and so I was really happy with the construct, but I knew I wasn't getting the planar correction that everybody was so eager to kind of get. And so I first started dabbling with DYNABUNION and playing with the jig. And I really fell in love with the staple plate compression technology. And as coming from somebody who loved my old construct, I think it really just identifies where the technology has really come. And so I think, Joseph, I am having a hard time moving, unfortunately, advancing. Perfect. Okay, so the traditional challenges associated with lag screw technique. I mean, we've all been in the OR. We all kind of give ourselves credit, I think, for throwing an appropriate lag screw. It's really not that challenging until it is, right? You take an X-ray and it's too short. It didn't get by cortical purchase, or it's too long and it's tickling the NC, or any number of things. And so I think if we're really honest with ourselves, lag screws should be really easy, and most of the time it is, but sometimes it's not, and it burns up OR time. We all have patients also that have poor bone quality, and so in those patients, we're not really going to throw washers into the forefoot, or maybe we are, but don't feel super excited to do it. And so interfragmentary screws are not always meant for everybody. And in that way, it can eat up surgical time. And if I was really being honest with myself, although I love my construct, I think I futzed with that interfrag more than I really should have. And so when I switched over to a compression plate, I saved a lot more time, but that's not the only real thing that we kind of benefit from. And so we can move on to the next slide. So when we talk about compression stable plating, we really identify this concept of gap recovery. And so we know at that arthrodesis site over time, we're going to get some reabsorption, and potentially that can create a non-union, right? With interfragmentary screwing, we're never going to get the same amount of compression that we do at the time of the OR placement. But with those stable plates, it obviously will push. So as it reabsorbs, it pushes and pushes together, and hopefully reduces that chance of non-union, that planar gapping, things that I was really nervous about with my initial construct. It ended up not being that big of a deal. Additionally, if you think about it, two cross screws at the level of the TMT are going to bind up more real estate. And so you get less cancellous to cancellous apposition. And so this idea of a staple plate or compression stable plate is avoiding that fusion site, allowing hopefully for more fusion mass. And then there's nothing to be said, or you can't stress enough the fact that applying a staple across a arthrodesis site, it just saves time. You can place one of these things in literally no time. And so you can eat up your OR time in some other way, I'm sure, but it certainly has made this more effective and faster in its placement, and something that I don't miss that old construct that I used to use anymore. So we can kind of move on. This is the traditional placement. Oh, sorry, I think we went one. Yep. This is the traditional placement of that staple plate. So even though we're making kind of that nice dorsal cut, I tend to make mine definitely more medial in the placement, and it gets everything in an appropriate alignment. Obviously, we're spanning that arthrodesis site pretty well so that it doesn't rip through any of that area. And then just nice, beefy kind of threads. Everything in this plate was made for stability. And that's what I really like. I'm not one of the TMT arthrodesis individuals that believes in micromotion. I know that there are other systems that kind of tout that as one of their aims, is to gain a little micromotion at the level of that site. It's just not my Kool-Aid that I drank. So I like robust, I like stiff, and I definitely think that applies with regard to this. Okay. There are a couple of plates available. So I think they've already introduced or discussed this new short plate. I'm excited to try that. I have not. The only plate that I've used so far with DYNABUNION actually is that very first one. It has that anti-drift bolt, which we'll talk about a little bit in the next slide. Again, I have not used the LC compression plate, but certainly available. It does not have that anti-drift bolt associated with it. But I have used that that Z plate before, just as a TN supplementation. They're great. I mean, it's easy to place. They're robust. They're strong, and so they have kind of some opportunities to offer you exactly the position that you need. So with regard to anti-drift bolts, there's a lot of companies, or this concept of kind of trying to gain a intercuneiform or 1 to 2 arthrodesis to beef up your, or to stabilize long-term the correction that you get. This was kind of built into the plate, and I had been throwing this outside of a plate a lot when I was first coming out. And it's nice because it angles kind of appropriately. It tends to always get the alignment that you're looking for. I think I've only had to change the angulation 1 or 2 times, and it was probably based off of the way that I've placed the plate at the time. But there's a couple of key features that you want to do in order to maintain that or to gain that arthrodesis. We really want to prep that inner space effectively effectively. The kit comes with a Hinterman, and with that Hinterman, I like to put it on and then rotate the metatarsal to expose that side. I'll either burr it or just rough it up with a ronger so it gets a nice bleeding kind of cortex, and then rough the side of that second metatarsal as well. At first, I think it used to come with a partially threaded screw, and now they've switched over to a fully threaded option. And then just making sure that you gain as much purchase on those cortex. Sometimes I run it all the way to 3, just as long as it's not in any joints. It seems like it makes it a little bit more stable. On rare occasion, I've had to remove this, but by and large, it's pretty effective at maintaining it. As long as it reaches arthrodesis, it doesn't seem that it moves that much. I will caution that I have seen a few just once before. It was placed a little bit too far into the inner space and it did fracture. And so I do think that there's a lot more range. I probably didn't obtain a true arthrodesis at that site, so it might have been just poor preparation on my side. But certainly the closer that you keep it to the inner cuneiform area, the safer it is and the less likely for fracture of the screw. So those are kind of my tips for that.
All right, so thank you, Dr. Steck and Dr. Grant-McDonald, for going through some of the introduction. And again, I'll just go through some of the system information here. Let me see if I can advance slides. Yeah, there we go. So as Dr. Grant-McDonald already talked about, there is a new DYNABUNION plate, which is a shorter plate that we had talked about a little bit more at the beginning. I have used all 4 of these plates, but my traditional plate for a DYNABUNION still remains the standard plate that I typically utilize. You do have some freehand wire guides, and we'll get into this a little bit more later if you decide that you want to use a different system or prepare the joint either with curettes or doing freehand cuts. So when you look at this, one of the key features of the system is this precision cut guide. And so notice on the left that essentially the head of the cut guide is faced distally. And so you start with a metatarsal base cut, and that takes about 1 to 1.4 millimeters of bone off of the proximal metatarsal. And then if you look on the right side of the picture, that the head is flipped, and then this is after reduction in both the all 3 planes, and then you're going to perform the cut on the cuneiform at this point after you've pinned it in place. And again, these cuts are about 1 to 1.4 millimeters, so very thin cuts, and it's probably the thing that impresses me the most with the design of the system. So again, you're going to get this flat to the skin for your metatarsal cut, and that's what's shown in the upper. So you've got placement followed by the cut, and then following after you've removed that portion of bone. And then you're going to flip it around and you're going to do your reduction. And so again, you're going to correct coronally as well as axially as well as sagittally, and then pin this proximally, and that's going to hold everything in position while you do your cuneiform cut. And then looking off to the right, you see that what that represents when you see those bent wires and the 2 arrows is the rack block is in place. And we'll talk about that in a little bit. But what that does is provide you maintenance of your reduction and also compression. So again, the C4 technique that the folks have come up with is cut the metatarsal, and then you correct, but you also flip that guide, and then you're going to cut your cuneiform. And then that picture off to the right, that kind of 10 piece with the 0 on it, that's your rack block. And so that is designed so that when you push it over the wires, it's actually smaller than the space, and so it compresses across your fusion site. So one of the things that they're talking about here is freeing up the TMT joint. So this is just a representation after everything has been placed, but you want to free up the ligaments around the joint so you can provide your correction, but it also allows you to get that cut block. It has essentially an intra-articular tongue that you need to be able to fit down in there so it's well opposed with the bone. And again, this rack block is realign and compress. It's an acronym. And so the 0 is for if you do normal cuts where you haven't had to come back. Let's say that you have a very rounded cuneiform or an abnormal first metatarsal base. They have recut guides where you keep the wires in place and you come back and shave off a little bit more bone. For each of those cuts, you go up on one number for this rack block, and it puts those wire holes closer together. And so they have from 0 up to 3 as far as recuts, and allows you to compress. So again, this is just a picture representing in the upper left. That's after you've done your cuts and you prepared your joint. And then in the lower pictures on the left, you're seeing that rack block in place, providing compression across your fusion site. And to me, this is one of the, again, another great thing about the system is you've got constant compression while you're placing your plates. So you're going to get your rotation reduction or that IM angle reduction alignment, and then compression, and then place your plate. Again, this is a traditional plate that you see on the right. That we've been using. I do use only fully threaded screws. When we first came out with the system, we thought that a lag screw would be better, but what we found is that it allowed some motion between the first and second metatarsals, and a lot of those backed out. With the fully threaded screw, we have not had near that issue. So again, what's new? Well, we have the standard plate, which has been around for several years now, and now we have a shorter plate, which provides a little bit less length necessary for your incision, and also allows so you don't have to come up quite as much underneath the tibialis anterior. And so you can see just the placement of the two different plates. They still use the staple compression, and they still have the availability for your anti-drift bolt, which is that screw that's fully threaded between the base of the first and the second. So this is just an idea of some of the changes that have been made in the plates over time. The standard plate is the bottom green plate. We did have some problems with that most distal screw being a little too plantar as your first metatarsal curves up in that area, and thus the new DYNABUNION Standard Plate. And then again, you have this short plate as a possibility for a smaller incision. Again, so when you look at these, just as far as the length and how they fit, existing legacy plate on the left, new standard plate, and then your short plate on the right. This is how they look from a lateral. And I don't know if you can see my pointer, but on that most left, on the left film, you can see where the olive wire was placed. You're very close to the bottom cortex of that first metatarsal, and by bringing that hole up, we're able to avoid missing the bottom of the metatarsal. Thank you very much. I'm going to turn the time over to Dr. Stotler for a technique overview.
Okay, thank you, Scott. Everything's been very good so far. We're going to go over a little bit of the technique itself here. I got a little video to show you as soon as I get some control of it. A little help there, Joseph. There we go. So as Scott mentioned, the four C's of this is to cut the metatarsal first, and then correct your intermetatarsal angle, and then cut the cuneiform, and then compress. And the key to this whole thing, in my opinion, is the compression, and the fact that we're getting the compression in the proper planes and the proper alignment is what's needed. Obviously, the correction of the rotation is extremely important as well. So we'll go through this little video of the technique and I'll kind of walk you through it a little bit. And I'll stop it as I feel necessary here. So my standard incision is a dorsal medial incision. It's about 45 degrees off of the first TMT joint itself. So there's our 4 steps that we're going to do in order to get this reduced. So basically I find dorsally and I find medially, and then I go right in between that to make that incision. I extend it just a little bit past the mid shaft of the first metatarsal itself. Some of these are a little bit tight. Some of them are okay. I do release the joint capsule. I will mention when you release the joint capsule with a knife up on the dorsal surface and the medial side, you can get that pretty easily with the knife, but plantarly is a little bit harder. And I use an osteotome and I just push it down into the joint, push it all the way down towards the floor. And you can also get a lateral release of that as well. That's very important because you can't get this cutting block in unless that first metatarsal is mobilized. You got to have that thing all the way reduced or released in order to get it down to where it needs to be. After we have that joint mobilized, we then place the cutting block into position to cut the metatarsal. It'd be very important that you are cutting the metatarsal itself. Looks like we're starting over here. And we'll secure that with the 2 pins within the metatarsal. I like to actually activate the windlass mechanism at this point as well. I do it on the cuneiform cut as well, just kind of a habit that I have. I'm holding it reduced and my assistant is putting the 2 pins within the distal cutting block. So that's in the metatarsal itself. And you want to make sure you do get these bicortical, and then you're going to make your cut for the metatarsal. You do have the option of putting that oblique pin. I just use the thumb holding it in place. Very important here is to get all of that bone out of there. You must get all of it out of there before you make your cuneiform cut. We do have a option of a little device in order to help reduce that, the rotation. You can add onto the pins. We do take a knife and make a little incision at the second metatarsal neck region and then reduce it. I personally like to just reduce it here first, and then after I get it reduced, then I place that pin into position. I believe that when you do reduce this, it actually corrects some of the rotation itself on its own, and sometimes you don't have to do anything with the extra handle. Once again, applying the windlass mechanism and then securing it to the cuneiform. I'm kind of looking at my angles here as well to make sure everything looks good, and then we make the cuneiform cut. Once again, I'll spend some significant time here making sure all of that bone is out. If I do not get if I have really sclerotic bone within that area, or I had a really angled cuneiform or TMT joint, I may make a recut at this point, which it just showed. That is not very often that I have to do that. If we do have that sclerotic bone, you can put this hinterman in there and then drill into that sclerotic bone, both sides, to get some good bleeding surfaces. You can also prep the second metatarsal base at this point as well. After you have that done, I do a preliminary reduction just with my eyes. If it looks pretty good, then I put this rack block into position. So let me tell you about putting that rack block. If you just try to put it straight down only, that metatarsal will sometimes translate plantarly. And so I hold my thumb underneath the first metatarsal base, holding it reduced, and then my assistant pushes the rack block back down. I then look underneath the rack block as best I can to make sure I have not translated, and I will take an X-ray at this time as well to make sure that I have not translated that metatarsal plantarly. It's something that I have seen before and made the mistake one time, and I'm just kind of diligent about it now. I like to actually just secure this with a wire obliquely and then take the block off. You can leave the rack block in a position and go ahead and put your plate and just the staple on itself at this point if you want to. I like to have great visualization of the entire joint to make sure I've got everything reduced how I want to prior to placing any hardware onto it. And so my preference is to remove the block, and I just take one wire, put it in, I put the second wire in, and then I remove one of them. My two construct that I use the standard anti-drift plate, and then I also use the LC compression plate with a free-handed screw going into the second metatarsal base. I use that actually quite frequently, just kind of old school of me liking to freehand that thing in order to get a little bit better compression on it. And it also provides me one additional screw distally within that plate. I'm just more comfortable with it. We do have the options of the other plates and also just a staple construct only. If you are going to put the plate on, we like to put the olive wires in first and then put the staple in. This will provide some compression. My preference is to put standard staples in. Sorry, the offset staple here, and then I like non-locking screws on the plate itself. As you impact that in, it will compress back down. You can look at this on x-ray. You can see that these arms may be parallel at this point, but they may actually be compressing just a little bit. And that is something that you can follow on your x-rays as well. You will get an additional 1.5 millimeters of compression after the staple is in. Various screw diameters that you want to use that is purely optional for you. We do bicortical on the distal screws. The most proximal screw on the proximal side of the plate, on the cuneiform side, is usually a little bit longer. The second screw, the more dorsal screw, is usually shorter. I try not to get into the second metatarsal with it if possible. After that's done, we will use this alignment guide to put that anti-drift screw in. There's a little line on there that will line it up very, very well, and it's highly accurate. You want to drill across and get to bicortical fixation on this. It's usually around a 34 millimeter screw, and the fully threaded screw is what we use. We then release the tension down the reduction device on it, and I check my motion to make sure it's good. I specifically check the second metatarsal head to make sure it's not too dorsiflexed or plantar flexed. Occasionally I have it at one occasion where I dorsiflexed it too much. Some people want to freehand it. They don't like jigs at all. And so you have the option of doing a pure freehand of the cuts itself. And then we have this little device you can put in there or in order to place the wires, and then use the rack compression block. You can reduce it with this if you want to. Some people who like this technique just reduce it with their hand. I don't think you get as good of rotational correction by doing that. This is the correction that you get with the rack block. And then you can secure it with whatever screw fixation you want to do or staples. Again, my preference is either the standard plate or the LC plate. And then I also like to compress the heck out of it. One technique tip is that you got to make sure that you get very good removal of all that bone within the joint prior to placing the jig or the implants. Thank you.
Thanks, everyone. Those are great reviews so far. We're going to go through some case reviews just to discuss, some of the things that we've gone through, and again, more tips and tricks as far as taking care of these. So this is a 43-year-old male. He had a traumatic left bunion and flat foot after a MVC, had a contralateral tib-fib fracture and IM now, but the left foot was gradually worsening over time. And so again, this is just his right side nail that was done. And then this is when he came to see me. And so this is just his left side. So just a unilateral deformity after the MVC. And you can see the talar head on coverage, as well as the increased intermetatarsal angle and traumatic bunion. So, we ended up doing a Z-cut calcaneal osteotomy, but for the purposes of this talk, we're talking about the DYNABUNION. So performed a dorsal medial incision in standard DYNABUNION technique. I did, in his case, do a modified McBride or lateral capsule release as he had a very stiff toe after the trauma. And so he's doing well at this time. I did use the anti-drift bolt and the standard plate for this. One of the things that was mentioned, I do keep the rack block on while I'm placing the plate medially. I place the staple and then I'll place a screw distally and a screw approximately that are outside of the pins, and then I'll take off the rack block at that point. So this is at 4-month follow-up. Again, you can see that he's fusing very well at the first TMT joint and has maintained his alignment and rotation. Another case, 54-year-old female, long-term hallux valgus with increased IM angle, fairly severe deformities. So she underwent standard DYNABUNION utilizing the jig. I did do an inner cuneiform screw. I was trying that for a while to see if that provided me more stability. And in younger patients, really what I started finding was that those screws broke. And so I've gone away from using a longer inner cuneiform screw at this point, but continue to use the anti-drift bolt to provide that intermetatarsal stability. And this is her contralateral side. And you can see that I did not use the inner cuneiform screw in this case. And lastly, 65-year-old female, again, significant bunion deformity with increased intermetatarsal angle. Again, you can see I'd used the longer inner cuneiform screws with her, and you can see where they do break, whereas the anti-drift bolt tends to do a little bit better. Anyway, I'll turn the time over to Dr. Steck.
Okay, thank you. I have two cases here. First case is a sorry for the poor quality here, but this is a 60-year-old female. She had long-standing painful bunion. Excuse me, large intermetatarsal angle, and we were able to correct that with the DYNABUNION. You'll notice my X-rays look a little bit different. I have not adopted the bolt. I used the plate and just fill out with screws. I'm definitely open to considering that, and maybe a topic for discussion when we're done. But I just over years, I just really haven't seen a well-healed lapidus recur, so I'm open to that, but I haven't been using the anti-drift bolt in my cases. This is another similar case, significant elevation of the first ray, and again we're able to do the same thing with the compression plate with the staple. She's done really well with this, and been very happy with that. So I think those are my two cases here. Is this mine? Maybe I did have one more. I'm sorry. Again, a very similar case. I've just been so happy with the reduction, particularly in the frontal plane, with these cases. They've all just really, I'd say, almost easy to dial in, and very predictable, reproducible, and efficient in these cases. Well, thank you.
All right, so I brought two cases as well of patients, and let me see if I can actually get this to move ahead. Joseph, I think I need your help again. I'm sorry. Okay, So my first case is a 56-year-old female. She actually works as a janitor at one of the local high schools, and she presented in my office with complaint of medial eminence pain and then subsecond. I live in a beach town, and so the women or the patient population here, they wear sandals pretty much all year round. And so it's not usually medial eminence pain that brings them in as much as it's that subsecond pain. And so I really want to make sure that I always pay attention to dialing that first ray down as much as possible and to reestablish true weight bearing on these patients. We have an F scan in my office. We do some deformity correction. It helps me to establish or to recognize that we are reestablishing appropriate gait mechanics. And so I use that a lot on my pre and post-op, especially bunions, but pretty much any surgery. And so I'll kind of add that in as well. So she had also some complaints of hammer toes, which we said that we would correct at the same time. She had lots of conservative treatment. She tried shoe gear modification and, change her activities and NSAIDs and all that stuff failed. And so we decided to proceed with surgery. So if you could move me along, Joseph. So preoperatively, she had a moderate to severe bunion, not aggressive elevatus. And so I was interested that her subsecond hurt so badly, but her studies on F scan, if you could advance to the next slide, did demonstrate that she was definitely overloading that second med. And so it's relatively fair throughout. She still is pushing off on the first rate, but definitely the highest peak at that second. She's not the best surgical candidate, diabetic, although she has intact peripheral sensation and she's well controlled, but she does smoke and she's a 30-pack year history. And we talked about that. I don't make people sustain. I just tell them to cut back as much as possible and to recognize that the risks associated with surgery. Okay, so we'll move forward. These are just some intra-op photos. I always utilize a plate underneath. It's actually just a stymon pin holder because, again, I'm super interested in maintaining that non-elevation of the first ray. And so we can just keep kind of progressing. And so I think we did a relatively good job at that. This is her immediate post-op, and then we can go on to her follow-ups. I have a pretty succinct follow-up structure. I generally see the person either 2 to 4 days following surgery, and we do the first dressing change and make sure there's no signs of infection. Then I tend to see them about 1 to 2 weeks following. They get a refill of their pain medicine at that point. Around week 2.5, 3, we start taking sutures out, make sure everything looks good. I then follow them back at around 3 to 4 weeks, and I take my first x-ray. As long as I see enough union at that TMT, I start weight bearing them in a cam boot, and I do that for 2 weeks following surgery. And then I'll send them immediately to physical therapy because I think that the range of motion at the level of the MTP is exceedingly important for a successful bunion. Depending on how active they are, they stay in physical therapy for anywhere from a month to 3. So the last patient I'm doing, she's a CrossFit instructor. And so she had high level demand, and she's probably going to be in physical therapy for longer because she just has higher level demand. I generally see them back at the 10-week timeframe, and I try them back on the F scan to see if physical therapy is truly and effectively getting gait mechanics back. I want to see that they're retraining them to get back onto their first ray, because again, it's never going to kind of function the way that it's supposed to if they don't really mobilize that joint. So if you can go on to that next slide. So this is her at her follow-up. I forget what week this is. It's probably week 10 or something like that. She's consolidated. It's back down. Everything's looking good. She had a little bit of a flat foot before. I failed to mention that. And you can see that's actually kind of corrected just with our Lapidus. That never fails to impress me that happens, but certainly it can kind of correct a plainness. And so we'll move on to the next slide. And again, that's pre and post. So it's really nice correction, sesamoids under. And then these are her comparisons. Oh, yep, see, sorry about that. So pre and post, you can see the sesamoids were derotated and all that. And then these were her F scans. And so you can see she's actually functionally loading that first ray again, and she is off of that second med, which I think, and I know because she followed up, is no longer an issue. She doesn't form that callus, and there's less discomfort associated with her ambulation. And so I think that that's kind of a nice part about this system too, is that it really helps you to kind of bring that first ray back. And it, as long as you're kind of doing the windlass mechanism, like they had kind of mentioned on each of your cuts, I really feel like you can dial that thing down and you don't have to worry so much about elevatus. So we can go on to the next case. This was my 34-year-old. She's a CrossFit trainer. She's super nice. She had bilateral bunions. We did both, about 10 weeks apart. And she did have medial eminence pain, but definitely that subsecond. She attempted sugar modification and things like that and was just ready to get going with repairing it. So she's a non-smoker, ideal. She's not, has no significant past medical history, healthy, all that kind of stuff. I just know that she's going to fight me about trying to get it again. And so I did her preoperative of scans. Again, she's loading significantly both sides on that subsecond. And so I know that what I have to do, I really need to dial that first ray down and get that MTP kind of functional post-op. And so we'll move on. So that's her pre-op. Clinically, she was not that impressive, but she's definitely a severe bunion, not significantly elevated, but, and deviation of the joint of the MTP, but certainly something that's not that difficult to kind of achieve. I'm a little bit different than some of the intra-op photos. I actually try not to enter into the MTP if I don't have to. I think if you go in there and have to reef the capsule, it makes the joint stiff. And I find it much harder to rehab. And I'm interested to listen to what the panel thinks about that afterwards when we talk about ancillary procedures. So we can keep going. Just some of the intra-op photos, gets that nice correction again with the cup black goes in, and then this is just putting that anti-drift bolt in. That picture is from the first case, and so I apologize for that, but it looks like the second picture is her lateral, and so we'll move on from there. And then this is her at her one of her follow-ups. I can tell that she hasn't initially started weight bearing in these x-rays too, because she's a little bit to the side, so she's probably not quite comfortable putting it flat down. And then we'll move on, and I think I have her F scans in here as well. Oh, nope, just her traditional follow-up. I'm sorry. So first post-op visit for her was probably 2 days following, and then it just runs through the same regimen. And I feel fairly confident that as long as I see some fusion at that 4-week time frame, I can start weight bearing them. Again, I'd like to listen to the panel on how they're doing their post-ops, if they're weight bearing them kind of right away. It is a really robust construct, and so I don't see a problem with that. I'm just hesitant. I really don't want any elevatus, so I haven't really challenged that weight bearing quite yet. And then at that 10-week mark, we take a F scan, and we'll see if those are up. And again, I did bilateral, and so this is her corrected. This is her post-op image, and then again, she's right on that first ray. And she was in physical therapy for quite a while, but she had high level demand, and so I was not that shocked by that, essentially. So those are the offerings that I have, and I guess we'll move on.
At this time, it would be great if anyone has any questions. I was just looking at the question and answer area, and I don't see any questions so far. We can go ahead and go to the kind of frequently asked questions. And I think Dr. Grant-McDonald really went through this pretty well as far as her bunion algorithm. But I would invite Dr. Steck and Dr. Stotler to, kind of give their, post-op regimen. I'll tell you mine very quickly. I'm similar to Dr. Grant-McDonald and bring them in at about a week. I want to change that dressing. I do have a PA that works with me, but I want to change all my bunion dressings. And so they come back and see me. We put them back in a bunion dressing. I'll let them put weight on their heel at that time. And then at 3 weeks, come back and take the sutures out, take an x-ray, and then begin them weight bearing in a cam walker boot. And hopefully out of the cam walker boot by 6 to 8 weeks out from surgery. Dr. Steck?
I'm similar too. I see them at 1 week for a wound check, between 2 and 3 weeks for sutures out. I do let them partial weight bear with a wedge offloading shoe, even initially, but then full weight bearing 6 weeks, as long as the 6-week X-ray looks satisfactorily healed.
So from my standpoint, I see them at 2 weeks, and they're a heel weight bearing from day one. And the secret to heel weight bearing, and I teach this to all of them preoperatively, is to keep the knee stiff, completely stiff, and then that operative foot stays in front of the other foot at all times. The non-operative foot never goes in front of the operative foot, otherwise you are putting weight on the front of it. So very important to do preoperative counseling on them on how to weight bear on their heel. I see them at 4 weeks. I use post-op shoe the whole time. I do not use a cam boot. They are heel weight bearing the whole time. They are wiggling their toes the whole time. They are full weight bearing at week 5, and I get a repeat X-ray at week 6 to make sure everything is good. If they are good, then depending on their motion of their toe, as if they go into physical therapy or if they just go into regular walking and into whatever shoe will fit. I do tell these patients their foot will be swollen for 4 to 6 months. Hopefully it's just 4 months. Lots of them are really shocked by how swollen the foot will be.
So I'll open it up to the panel to talk about any of the adjunct procedures. Lateral release, I'm probably about 25% somebody that has just a very stiff hallux that can't be reduced. And I tend to do it after my reduction, just so I know what I'm going to get as far as after I've done the intermetatarsal reduction as well as rotation. Aiken osteotomies, I'm not I commonly say to the fellows, the only Aiken that I regret is the one I didn't do. And so fairly aggressive doing Aikens. As far as doing other adjunct procedures, a lot of times for me, if they have a hammer toe, I'll do it. But a lot of times, like Dr. Grant-McDonald alluded to, they have pressure under that second metatarsal head. So I may be doing a while osteotomy or something like that in order to just reduce that overload, because you do, even though you can either translate or plantar flex the first tray a little bit, you do shorten about 3 millimeters to 4 millimeters when you do this. As far as a capsular repair, I agree with the panel in that, trying to stay away from doing something to the medial capsule is beneficial, because that does cause the hallux to be stiffer. If I do end up doing a silver bunionectomy and a capsule repair, I try to do an L-type capsular repair, because I think it is less stiffness producing than a champagne glass repair. I think with that repair, you can advance kind of that plantar cut and actually cause more stiffness, especially in dorsiflexion. So those are my thoughts. Open it up to the panel.
I'll go first or second. I'll do the Lapidus and then just really evaluate the first MTP joint. If there's if it's just not reduced the way I want it, I will do a lateral release, Aiken if needed. I completely agree with the wild procedure on the second hammer toe if that's their main complaint, and I also do a L-shape capsular repair. I think that I think that the swelling is much less and the recovery is usually quicker if I can stay out of the first MTP joint, they tend to again just get better more quickly and have quite a bit less swelling in my experience if it's not needed. So certainly these procedures are not needed on everybody, just usually case by case for these adjunct procedures for me.
I'll go next. I do lateral release probably 50% of the time. I do it after the reduction as well. I just want to get those sesamoids very well reduced over there. I try to avoid a medial capsulotomy at all costs. If I get them reduced and they still have a prominent eminence dorsal medially, I may make an incision there and release the dorsal portion of that joint capsule and just take a rongeur to cut off that little bitty edge there. I do not disrupt the plantar portion of the medial joint capsule. I have a friend who believes in repairing that the sesamoid ligament over there and bringing it over. I'm not a big component of that whatsoever. As far as the second toe is concerned, I'm a big plantar plate guy. I hate the plantar plate repair systems that are out there. I think I've had a huge amount of complications from them, from just reaction to the suture to tearing up the bone and the cartilage. And so I just have gone back to my traditional Girdlestone Taylor with a flexor to extensor transfer and have been extremely happy with that with a very high success rate. And as far as the aching is concerned, I probably do that. Like Scott said, the ones that I hate are the ones I didn't do. And so I have a very low tolerance. If there is any crowding onto the second toe after reduction, I will do an aching.
I would agree pretty much with most of the things that everybody said. Aiken pretty much every time. Lateral release more consistently than I think the rest of the panel. I probably do it about 80-90% of the time, and there's only been a few times that I really felt like it destabilized it, but it seems to me like it helps to get the reduction of the sesamoids. It's really helpful in arthritic, like everybody had mentioned, arthritic patients or really stiff MTPs. Hammer toe repair, I try not to touch the second MTP. I really think that if I can reestablish appropriate weight bearing through the first ray, most of the pain subsecond largely goes away. And so I try, unless there's something in there, like I agree, Dr. Shawn, that if there's plantar plate tear, obviously that needs appropriately addressed. And if there's a parabola issue, then I will address it as well. But yeah, I try to stay away from most MTP things. And then capsular repair, gosh, I have spent some time debating whether or not to go in on a medial eminence, because there's always that redundancy, and I always tell myself it'll go away. But it's just a cosmetic thing, and I struggle with it, and so I try not to, and I really don't go into it very often, but every once in a while I'll have somebody that just has just a big old bursal change in that area, and I end up kind of doing something over there and taking off a little spurring or whatnot. So I try not to, though.
I think we've already gone through post-op protocols, so I think we can skip that.
All you guys
Joseph,
made this so early. I'm going to try it. I liked your recommendation too about keeping the legs straight and ahead of you. I'm just a chicken, I think.
Yeah, it's extremely helpful, and they can be completely non-weight bearing on it. It's a short stride and it's a shuffle gait, but I'd make them do it pre-operatively so they know how, so they're not all drugged up and then trying to figure out how to do it.
No, I love that too, because I'd never thought about that, not putting your foot in front of the operated foot, your contralateral side. Joseph, I can't see the thing in the bottom to see if we have any questions that have come up. It's disappeared off of my screen. So are there any questions that we need to answer?
Yeah, we've got one in the chat right now. It's preference for technique of removing bone from base of the second. Are you talking about going through that inner? I'm thinking, is that going through the inner space, maybe prepping for that anti-drift bolt? I'm thinking that might be what they're referring to.
So I think this has been alluded to by the other surgeons on the panel, but there's a Hinterman device that you can put onto the wires that will help you separate the proximal first metatarsal from the cuneiform about 8 to 10 millimeters. And you can then see into that space, and then it's really dealer's choice. I go in there with a rongeur and try to get the lateral part of the first metatarsal, and then also that base of the second with the rongeur to try to get down to some bleeding bone. I have a little bit of concern about, drilling that and really doing a preparation at the base of the second, because I don't want to cause a stress riser and then have them have a stress fracture through that area. So I just try to get down to the bone, and I will also try to get onto the lateral part of the medial cuneiform into that area. So when you look at Don Bohe and John Anderson out of Grand Rapids, Michigan, they do a lot of Lapidus fusions, and they've done a lot of screw technique, the cross screw, but they talk about when they're going dorsally and doing a burr hole into that base of the second and medial cuneiform articulation. And when they did that, they had a dramatic increase in their fusion rates. And so, I try to replicate that and do that in some way.
I do the exact same. That's exactly how I do it with a rongeur.
I agree. Don't take much bone off the second. Just roughen it up just a little bit, get all the soft tissue off of it, and then that shear strain relief bone grafting that Don and John do is excellent.
I don't see any more questions in the chat. So if there were any topics that you all wanted to discuss that maybe were not brought up, any questions that you'd like to discuss real quick, we can go a few more minutes. But if not, we'll carry on, close out this thing.
I had a question. I mentioned it in my case presentation, but does the other panelists feel that it's strongly a big detriment to not use the anti-drift bolt? And I just have people that in the past, when I've used it, they've had issues with it, and stress fracture was brought up. So I've elected not to use it for now, but again, I'm open to using it if there's a good reason. Have you seen some of these come back when you haven't used it, or what are your thoughts on not using the anti-drift bolt?
I think in situations where I've had to take the anti-drift bolt out and it didn't reach union in between in the inner cuneiform or 1 to 2, I noticed like a small amount of change, and maybe it was a little bit more prominent. It didn't reoccur in the way that like you see bunions reoccur with like Austins and stuff. But yeah, I mean, like a subtle reoccurrence. Yeah, I've seen that when I had to take out a 1 to 2 or an anti-drift.
Yeah, in our practice, we saw, not infrequent instability, more of an inner cuneiform instability, and then you have your first and second angle increase again. I tend to again do the anti-drift bolt. I've had good luck with the threaded or the fully threaded one. The partially threaded did not work, and so I would not use that.
Yeah, the reason why I use the anti-drift is for the latent diastasis. I'm not necessarily trying to get a fusion. If I get a fusion between the inner cuneiforms or second metatarsal base, I'm good. I'm happy with that. But definitely the ones that do not get a good fusion, I have had some second metatarsal base pain. Never had a stress fracture, but I have seen some loosening. Those are usually with my free-handed screw, not with the anti-drift screw itself. But the recurrence that occurs is just a mild increase of that IM angle, and it makes the patient mad because they think that their bunion's coming back and it's just going to continue to get worse. And so it's just some coaching that I have to do with them at that point. And so that's the reason why I put it in.
Perfect. Looks like we have another question in the chat. So use of the system, ever using bone graft when you're dealing with short. So in cases when you might
I do not use bone graft. You know, I try to do kind of the classic, do your cuts, irrigate, and then make sure you've done all your preparation as far as the second, and then I'll do some drilling into the cuneiform and the base of the first, but you get a really good apposition between the two. And in my opinion, if you're getting that good apposition, there's not really a role for bone graft, because it may actually provide dead bone in between your two pieces. I think if you're doing a revision for non-union or something like that, then putting something in there to stimulate is applicable, but I don't think that's for every case.
Yeah, I don't use any bone graft for primaries whatsoever. If I have a non-union, then I actually use an oats plug and take autograft out of the calcaneus with the oats system and put that straight up and down it, leaving all the previous hardware intact. And if it is not loose, that's extremely successful in getting them to heal. Whether it's a bunion or just a regular fusion across a second or third TMT, it's an excellent technique.
I'll put biologics in compromised patients for sure, which are probably most of my patients, but.
All right. Well, I don't see any more questions in the chat. So thank you all